some general topics here. The approach to the poison patient is this list of things. And by the way, just to clarify, these are all of these topics were taken from the list of the C-SPI test, sort of the core content. So hopefully we'll go through each of these things. As I said, some of these are a little basic, some of these are a lot more advanced, and we won't be able to get into all of the specific details, but I'm hoping to go over this group of topics in the next roughly an hour. So start with supportive care, the things that I think that they might ask about. Supportive care is it's like everything we do in medicine, essentially, with the exception of antidotes. I would think that one of the things to focus on would be indications for intubation, which really should be mostly respiratory failure, which is the failure to oxygenate if they aspirated and they've got, whiteout of both sides of their lungs, and you can't oxygenate them, then sometimes that will get better with intubation, sometimes. But more commonly, if they can't ventilate, from sedative hypnotics or something along those lines, they're just not breathing. And then there's this sort of highly controversial thing called airway protection, which I think is most of the reasons why people are intubated. But and really what that's referring to is this person is unconscious and they don't have airway reflexes, meaning that if they vomit in the next some period of time, that they would not be able to protect their airway, they would not be able to cough out the vomitus, they would inhale and then or not do anything at all, and the vomit would go into their lungs and cause them to aspirate. So I say controversial because I think there's some relatively, this is probably the primary reason why people get intubated, but there's a recent paper suggesting that we might be able to not intubate as many people as we have in the past. The other thing, I think the third reason I didn't put in here, but I probably should just mention, is what is often referred to as predicted course, which means you all know that someone who takes a huge bupropion overdose, the moment that they become unconscious, that you're in for a 2-day critical care course. So you would intubate that person because they're going to be intubated at some point in the next 2 days for sure. And even if they don't meet all these criteria, then we know that they're going to be intubated. So you might as well do it now when they're not hypotensive and they're not, hypoxemic and all of those things. So, all right, a little bit more review. This is more ACLS stuff, and I don't know how many questions there would be in this, but treatment of bradycardia. ACLS changed their dose of atropine from 0.5 to 1 a couple of years ago. So that, I don't know if that has been, if everyone that we, all of the physicians and healthcare providers that we talk to on the phone are totally aware of that. But I have no problems with the 0.5 dose. I think it works just fine. I think the problem is that sometimes it doesn't work and you have to give the other 0.5. There is the occasional person who will get more bradycardic with 0.5 milligrams, and that's the reason why they got rid of that dosing. So just so that you're aware. And then atropine is indicated really for unstable bradycardia. We see a lot of bradycardia with heart rate, 28, and the blood pressure is 120 over 80. Probably not an indication for atropine. That's only if they really are unstable. But what you can do for those folks, and I'm assuming that it's not DIG, and you can just give the DigiFab, but for bradycardia, ACLS still lists epinephrine and dopamine. Dopamine, I think, has fallen way out of favor for this indication for bradycardia, but it seems like there are still practitioners out there that go to dopamine first line. I think the modern medicine really goes toward epinephrine as first line for bradycardia. But there's still a lot of people there that still grab for dopamine. Dopamine was the first line in ACLS for decades. I think the main reason it's not has nothing to do with toxicology. It has more to do with sepsis and cardiac issues where dopamine is an indirect acting pressor. So it causes the release of norepinephrine and epinephrine rather than actually stimulating the receptors itself. And if you're septic, then it doesn't work very well. For toxicology associated bradycardia, it probably works just fine, but again, it's fallen out of favor for other indications, so I kind of make it second line now. And then obviously hypotension, IV fluids, lactated ringers and normal saline. Personally, don't have a preference. Some practitioners have a very intense preference one way or the other. Trauma surgeons tend to really love, or surgeons in general try to love lactated ringers. That does seem like a reasonable choice. The only time this becomes an issue for specifically for me is if you're giving liters and liters. So if you have someone who took a beta blocker or a calcium channel blocker and they're getting, 5, 6, 7, 8, historically people have gotten more, than 8 liters, which we probably shouldn't be doing anymore. We probably should give a couple of liters and then switch to a vasopressor and add on vasopressors. It does become an issue because normal saline has a lot more sodium than is physiologic, and you can get a lot more chloride than is physiologic, and you can get a hyperchloremia, which can produce a hyperchloremic metabolic acidosis. So, I don't care until the 4th liter. And then after that, if you want to switch to lactated ringer, seems very reasonable to me. And then vasopressors, let's just go through a little bit of a review of vasopressors. But before we talk about the pressors themselves, we have to talk about the receptors. And I could definitely see, I recognize this is a review for all of you, but I could definitely see some good questions from this chart. We have our alphas and our betas, and then I'll throw in the dopamine receptor there as well, although it's probably not very important in the long run, but more on that in a minute. There's alpha 1 and alpha 2, beta 1, beta 2. Alpha 1 stimulates vascular smooth muscle to contract. So that is the receptor that is on the arterioles. And if you stimulate alpha 1, then it causes the arterioles to contract, increasing systemic vascular resistance. Alpha 2 is almost entirely in the brain, and that is more when we start talking about clonidine and dexmedetomidine, and that's stimulation of alpha 2 decreases sympathetic outflow and makes you sedated, maybe bradycardic and hypotensive. So it's not really a pressor effect at all. The alpha pressor effect is alpha 1. Beta 1 is in the heart. Stimulation of beta 1 increases heart rate, increases contractility. And then beta 2 is more at other places outside of the heart, things like the lungs. Beta 2 stimulation causes bronchodilation and in the uterus. So it has the opposite effect. It has vasodilatory properties, but not on the heart or on the arterioles. And then D1 dopamine receptor is mostly in the renal artery. Probably not particularly important. It used to be thought that it played a significant role, but it probably doesn't play a very, very significant role. And again, it just to manipulate renal, to dilate the renal artery to increase blood flow. But we don't use renal dose dopamine anymore because it probably doesn't work for that. So now let's convert these receptors to vasopressors, and then we can figure out what we would give on any particular for any particular patient. So norepinephrine stimulates alpha predominantly. At higher concentrations, norepinephrine, epinephrine, dopamine, they all act kind of the same. They all stimulate everything. As I don't have to explain to specialist in poison information that overdoses, drugs become less specific. But at regular therapeutic doses, norepinephrine is mostly alpha, so it's going to mostly cause vasoconstriction. So if you are vasodilated, norepinephrine is a great choice. Epinephrine is going to be more beta, which is going to cause increase in heart rate and increase in contractility. So if you have someone who is bradycardic or has decreased contractility from their overdose, epinephrine is a better choice than norepinephrine. I don't know how you guys memorize this. I just remember this like EBNA, E-B-N-A. I have no idea why it works in my brain, but it does. Epinephrine beta, norepinephrine alpha, EBNA. And somehow that stayed in my brain for 25 years. But epinephrine stimulates beta, so increased heart rate, increased contractility, norepi alpha, and vasoconstriction. And then at higher doses, again, norepi stimulates beta, so you will get some tachycardia. The drug that is really effective at just alpha is phenylephrine. Phenylephrine is just an alpha agonist. So if you just need vasoconstriction, I think the example that's the easiest to remember for me is like tricyclic antidepressants. They cause tachycardia and vasodilation, so that you get tachycardia and hypotension. If you use something like norepinephrine, honestly, most of the time it's going to be completely fine. So I'm not too worried about that. But if the fear about using norepi is if their heart rate's already 160, then you're going to give them the alpha effect, but you'll get a little bit of beta, and now their heart rate's 180, 200, and now they have inadequate filling, and you can get hypotensive. So if someone has a pure vasodilation, amlodipine is another great example of this. Phenylephrine would be my first choice for that type of vasodilatory. Nifedipine, one of those types of overdoses. And then dopamine stimulates dopamine receptors, vasodilates the renal artery, probably not very important in the end, but then releases norepi and epi and stimulates beta and alpha. Again, dopamine is mostly fallen out of favor because it's an indirect acting drug. If you have something like sepsis, you've been releasing all of your norepi and epi for 5 days now. That's what kept you in compensated shock. The reason you're in the hospital now is because you decompensated because you ran out of all of your epi and norepi, and so dopamine doesn't work very well. That really has nothing to do with toxicology. So if someone wants to treat bradycardia with dopamine for toxicology issues, I don't have a problem with that. I just go with epi first because I think people are getting more used to that. And then vasopressin has its own receptors. It causes vasoconstriction. I would say it acts similarly to phenylephrine, obviously different receptors, but causing simply vasoconstriction without the tachycardia and out the increased contractility. Now, this probably won't be on your exam, but I just wanted to put it in there because I think it has come into the norm and is pretty much standard of care at this point, which is push dose pressors. Push dose pressors, classically epinephrine and phenylephrine. The idea is if you had someone who was hypotensive and bradycardic, say a calcium channel blocker overdose, starting them on the lowest dose of epinephrine infusion, waiting an hour to see if it works, and titrating up, it seems like you've wasted all of that time. The more rational way to do that is to give them boluses of epinephrine until you get an effect and then start the infusion. And that's sort of the idea of push dose pressors. So there's lots of instructions online. There's instructions on our guidelines and our fast facts. But what you end up with is a syringe with epinephrine, and usually you end up with 10 mics per mil. And so people will say, they might say to you, I gave 4 mils of push dose epi. That would be 40 micrograms of push dose epi. Phenylephrine is 10 times the concentration. It's 100 mics per mil. but the doses end up being the same. For most patients, the dose is 2 to 4 milliliters, which for epi is 20 to 40 mics, and for phenylephrine is 200 to 400 mics. The effect is about the same. But again, I don't think it'll be tested on this, but I think this is an important concept to bring up because it has really become the norm, and it does make a lot more sense than just starting on an infusion. All right, very good. Moving on to metabolic acidosis. Again, we're still in the supportive care portion. We'll talk about metabolic acidosis a lot during the next 3 days. So I just want to underline a few things. I put mud piles up there because I could see a question, you being asked a question that would require you to go back to the good old mud piles list of metabolic acidosis. On the right of the screen, I put what we prefer now, which is CULT. And the reason I prefer this mnemonic, although I have to admit I still use mud piles, and I'll explain how, is because it tells us what to order. So ketone, ketonemia, DKA, AKA, starvation, ketoacidosis, uremia is obviously order of BUN, hyperlactatemia, and then the T is for toxins, and that's all of the organic acids that don't cause hyperlactatemia. So if I had a patient who had a metabolic acidosis and had normal ketones, normal BUN, a lactate of 20, and then I would stop and say, oh, lactate of 20 without ketones, this is a hyperlactatemia or a lactic acidosis. And then I would go back to mud piles and say, what causes elevated lactate? And so let's go through mud piles, because I think even though you do this mentally all the time, I could see somehow questions on this and needing to use this. The M is for methanol and metformin. Of course, metformin increases lactate, so that goes under our L for CULT and CULT. We already talked about the uremias and the ketonemias. Paraldehyde is a sedative drug that has not been used in, I think, about 50 years now. I think 1972 was the last time it was used, if I remember correctly. So it's a placeholder. And the other thing would be like fenformin, which also has been off the market for 30 years. So but otherwise it ends up being mud aisles, and that makes no sense. So the I is for iron. Of course, if you suspect that you can get an iron concentration, INH causes seizures. Seizures cause hyperlactatemia, so INH falls under the lactate group. Ethylene glycol and methanol do not increase lactate significantly. So getting back to the CULT side, that would be a person with a pH of 7.0, normal ketones, normal BUN, relatively normal lactate. Why do they have an acidosis? It can't be KUL, it has to be the toxins portion, and that ends up being just the acids. So methanol and ethylene glycol are broken down into acids, and valproate, salicylated ibuprofen are acids to begin with. These two are the toxic alcohols are the ones that are most common. All right, I know we're going quickly here. We're just moving through. We just did all of acidosis in about a minute. So stop me if you have questions. We're going to move on to limiting absorption. So GI decontamination, and then we'll talk a little bit about getting rid of a drug that once it's absorbed. So we can limit absorption by emptying the stomach. We can do that by gastric lavage. We can do that by emesis. Can block the absorption with charcoal. We can decrease the transit time by giving them cathartics, which we won't do, or whole bowel irrigation, which we will rarely do. So what I'm going to do is the core content said, each of these we should talk about the indication, the complications, the need for monitoring afterwards. So let's do that. In general, I think it's really important that before we start talking about doing any of these things, the toxin still has to be present in the GI tract, right? I mean, it sounds like a totally ridiculous thing, but we do get these questions from time to time. It's like, should we give charcoal? And the thing that they ingested was absorbed hours ago. And so the answer is always going to be no, because there's absolutely no advantage whatsoever. So, and I think that the primary contraindication for activated charcoal, the historically activated charcoal, and actually in emesis and whole bowel irrigation and lavage, these were all standard for like everyone who ingested something. I think the most important contraindication, and the reason why we do this very little now, is because it has to be a life-threatening or at least a concerning ingestion. The non-toxic exposure will never benefit from gastric emptying, because they're going to do fine no matter what you do, unless you hurt them. So, so let's go through each of these. Gastric lavage is something we very rarely do. It mechanically removes the toxin from the stomach. The indications are something that is life-threatening, and I think that is probably the indication that most of us are using, is if I'm standing at the bedside thinking to myself that this person is going to die no matter what I do, then I would consider doing gastric lavage, and it's early enough. Then I would consider doing gastric lavage. So the times we see it is extremely rare, but it's usually the ones that we're thinking to ourselves, this person has a very high chance of doing very, very poorly. If there's an easily treatable antidote, then we shouldn't be doing lavage, because we just give them the antidote. And then there's this time that is often quoted. I could see it being a question, that gastric lavage, and I can extend this into activated charcoal. That they say, it's not indicated after 1 hour after ingestion. So I think if you get a question on this, the answer is 1 hour, that it's effective for up to 1 hour after the ingestion. I think clinically speaking, if there's pills in the stomach, then it's still an option. The studies looking at this 1 hour were mostly volunteer studies. So, they gave someone, I don't know, 4 acetaminophen tablets and then did gastric lavage, and they got 4 tablets back, and then they gave someone else 4 acetaminophen tablets and they did gastric lavage 2 hours later, and surprise, surprise, they didn't get any acetaminophen back, right? So that's not the same as what we see. So I think clinically we have to have evidence, so we have to suspect that there's pills in the stomach, otherwise you're wasting your time. But sorry, they've chosen this time to mow the lawn, so let me just close my window. Hang on a second. It's pretty much universal every time we are talking on something like this, that they're gonna start the leaf blower. So if you have not participated in gastric lavage, this is the tube. It is big. It's really big. So this is a penny. This is like the biggest capsule I could find. They are very, very big. They're like a garden hose. This is gastric lavage. You see this person is already intubated, and a bite guard here. You put the tube down there, and then you put charcoal in, and then you've got this kind of, most places have this double-barreled system where you are drawing water from a big bag and then putting it in the stomach and then sucking the water out. You don't need this advanced stuff. You can do this with a 60cc syringe or 120 milliliter syringe, where you just put water into the stomach and then pull the water back out again. But it is a bit of a procedure. The complications, of course, is if you're sticking a big tube somewhere, you can put it through someone's esophagus or their stomach. I think that would be extremely difficult to do. But if you're not trained in how to do gastric lavage and you don't measure, it is a relatively rigid plastic tube, so it's certainly a possibility. And then and this was, by the way, not a gastric lavage. This was a feeding tube, but I thought it was kind of a cool picture. So you also with lavage can push the stomach contents through the pylorus into the duodenum, and so that might be problematic as well. Other cases where we can't use gastric lavage or they're contraindicated, caustic ingestions because the mucosa is friable and you can put the tube through the mucosa. Hydrocarbons because we don't want people to vomit. If they drank a bunch of kerosene, it's really not a huge advantage of getting it out to begin with, but also the kerosene is gonna make its way into their lungs. So you just kind of leave them be. And then children, this is a huge tube. I would say anyone under 15 probably can't get lavage. They have to be adult size. This tube it's quite large, and it has to be large in order to bring back intact pills. So if it's a tiny tube, if it's an NG tube, that'll work for a liquid, but it's not going to work for tablets. You really do need the large lavage tube. All right. The other way to empty the stomach is emesis. It's no longer an option really because we don't have syrup of ipecac anywhere. I think it's been not manufactured for a decade or so, so there's no supplies left. Historically, people used apomorphine. The indication, just in case you get a question there, first of all, 88% of people who get ipecac throw up, 96% if you give them a second dose. So pretty much everyone throws up. The indications are you have something that isn't easily treatable. Maybe it doesn't adsorb to charcoal, doesn't have an antidote, and getting the pills out of the stomach will be beneficial. If the pills aren't in the stomach, then it's useless. So don't do it. If you have some X-ray with iron tablets in the duodenum, then this is not going to help in any way. I think we still keep this concept alive for two things, lithium and iron, because both of them don't adsorb to charcoal very well. But clinically, this is not an option for us because we have no syrup of ipecac at all. Now we have activated charcoal and we're using it less and less. Trying to predict some of the questions you might have. Activated charcoal is actually just charcoal. It is burned organic matter. For some reason, I think based on one reference, people always love to say that it's from coconut husks, which I think is true, but you can burn anything and make carbon ash. They then take the carbon ash and they treat it with carbon dioxide to activate it, which means that it produces these pores. This is a electron micrograph of a one particle of charcoal, and you can see it has these huge crevasses in here and lots and lots of sort of very, very porous. And if you cut that charcoal in half, you would see is these little crevices, and they have all these little spaces in there. They're very, very small spaces. Molecules and chemicals find their way in there and then get very weakly bound by all of these forces that I remember from medical school. I haven't remembered since. Van der Waals forces and ion-ion and dipole forces, but they're not covalently bound. They're just held in place, and because they're at the base of a crevice, they kind of loosely stay there, and that's called adsorption. So when we give charcoal to someone and we want to bind, verapamil, the verapamil is finding its way inside that charcoal. So are all of the other chemicals and molecules that are in your stomach or GI tract, and they're finding their way in there, and then they're just being loosely held. And the idea is you'll defecate out the charcoal with the verapamil or amlodipine or whatever it is you get for. And that is called adsorption, not absorption. The dose is 1 gram per kilo. So if you have a 1-year-old, that's 10 kilos, you give them 10 grams of oral charcoal. If you have a 80-kilo adult, it could be 80 grams, although I think most people just stop at 50. Although there are some places that give 100 up to 100. but I think most are just giving 50 grams for an adult. And then there's this concept of a 10-to-1 charcoal to drug ratio, which is means that charcoal is optimally binds a drug if you can give the person 10 times more charcoal than they ingested. Now, I'm only mentioning that because I guess there could be a question on it. It doesn't really come up very often. Most people who ingest, big overdoses are below this ratio, and those that are not are so far above that there's nothing to do about using that ratio. The one time I use this ratio is little kids, like a little kid who eats 10 milligrams of digoxin has a fair chance of getting sick. But according to this ratio, we only need to get that kid 100 milligrams of charcoal. So you would offer them 10 grams, but if they took 2 sips, I'd be happy. So that's how I use the ratio, but probably just good enough to just know that the ratio exists, that there's 10-to-1. As with all gastric emptying, you don't give charcoal to people who are going to be totally fine without it. So potentially harmful. The toxins adsorb to charcoal. And again, this number comes up this 1 to 2 hours after ingestion. Again, if we think there's tablets or something in the stomach, the best example probably is salicylates, right? It doesn't matter that it's 10 hours after the ingestion. If they have a giant Bezoar, then we're going to keep giving charcoal. And then the complications are often, it is said that vomiting happens after charcoal, and that is 100% correct. Interestingly, when you look at there's 2 randomized controlled trials of activated charcoal. The vomiting rate is no different at all if you give charcoal. I think what happens is you have someone who's going to vomit in the next half hour, and then you force them to drink stuff. So we have this association with charcoal that it makes people vomit, and it does. What I suspect based on these studies is that if you gave them a glass of water to drink, they would also vomit. So it's people who are they're going to vomit in the next, say half hour or so. I would only say, looking at the chat and Mike's question, for extended release formulations, I don't know that there's any guideline, but and I'll mention this in just a minute when we talk about multi-dose. I would consider using multi-dose charcoal if people ingested an XL or SL formulation. That certainly does seem reasonable. I don't know if that's getting to your question or not, Mike. Contraindications. You are not conscious. I've talked about unprotected airway before, right? You're not conscious and you don't wake up when you're concerned that someone's going to vomit and they're going to aspirate. Well, we shouldn't be putting stuff in those people's stomachs. I think this is kind of the norm now. Back in the day, people would get a sternal rub and wake up enough to give them charcoal. Please don't do that. Oh, I see. Yeah. I don't know of any guidelines. So Mike was asking if we should give charcoal late, going back to the indication, if they took an extended release. Or my feeling is this: as the first dose, like a single dose charcoal, if you think that there are still tablets in the stomach with drug in them and they don't have a contraindication, I think it's very reasonable to give activated charcoal. Honestly, no matter how long it is. I think if you have, I'm trying to think of how you would have evidence of that, but maybe an X-ray, or someone took an XL formulation and it doesn't peak for 6 or 8 hours. It does seem very reasonable to me to give charcoal, up to 6 or 8 hours, because the drug is still being released from that tablet. I don't know if that answers. So the list of things, there's lots of Yeah, so sustained release products, you know, yes, so a couple of things. Sustained release products, they will have moved on, but giving charcoal in your stomach, the charcoal will also move on. And so I think the hope of giving charcoal late is that the charcoal will kind of catch up. There also may be tablets that are still in the stomach, but you're right. There's nothing about a sustained release formulation that makes it stay in the stomach longer. It will stay in the stomach for some period of time and then move to the duodenum and to the small bowel and release probably most of its drug there. That's fair. Yeah, and so the caustics and hydrocarbons are contraindications because someone is, well, the hydrocarbons because we don't want to put anything in the stomach because we don't want them to throw up. The caustics is mostly because the damage is already done and we're going to make our endoscopy colleagues view of the esophagus and stomach very, very problematic. And then the things that are not adsorbed, this is one of the mnemonics I've seen, but I think really what it comes down to is iron and lithium are the main pharmaceuticals that are not adsorbed very well to charcoal. Metals, it's kind of a mixed bag, but we always include it. And then the alcohols, the volume is so large that the amount that charcoal would adsorb is meaningless, and so we wouldn't use those at all. All right. Yeah, and what Roberta was just saying is, yeah, so there is some evidence that activated charcoal decreases within the first 4 hours, decreases the number of people who have an acetaminophen concentration over the nomogram. So that's one of the few things, we can't say that activated charcoal decreases mortality or anything like that, but we can say, at least in one study, that giving charcoal to people who just took acetaminophen decreases the number of them that will be above the nomogram line. And if they're above the nomogram line, they get admitted and they get IV NAC. And so that seems like a meaningful intervention in those cases. All right. Cathartics we don't really use anymore. I think this is of historical interest. People giving mag citrate and stuff to try to increase gastric emptying time. As you all know, most drugs peak in the first 4 hours, and there's no way that a cathartic will ever move your bowel contents out in 4 hours. It's not even a possibility. The one thing that is left is sorbitol, which occasionally happens in activated charcoal. So I think one of the things with sorbitol is that when it's mixed with activated charcoal and it's given repeatedly to very small children, it has led to dehydration and low sodium, so hyponatremia. One dose is not going to be a problem. The nice thing about sorbitol is not for the cathartic effect, but it makes activated charcoal taste delicious. And so my feeling is if you want to give to a child activated charcoal with a little bit of sorbitol in it, I'm not against that, but as long as it's not more than one dose. But I think if you get a question about using sorbitol in pediatrics, the answer is no, don't give it. That said, clinically speaking, most of those effects were multiple dose activated charcoal with sorbitol, which is problematic. Whole bowel irrigation. Another thing that we don't use very often anymore, kind of had its heyday and it has kind of fizzled out a little bit. Polyethylene, so the contents are polyethylene glycol 3350. 3350 is a reference to how long the polymer chain is. So, if you make the polyethylene glycol smaller and smaller and smaller and smaller, you get into other substances. And so I don't think that 3350 is going to be very important, but it's a very, very long chain. And because it's that long polyethylene glycol chain. It doesn't get absorbed at all. It just travels through your GI tract. And if and just carrying the theory being it carries the tablets with them. Now, it makes sense, right, that you can move if you give 2 liters per hour to someone by NG tube, and it has to be by NG tube. If like if you've ever the colon prep, which is a gallon, it's 4 liters. The vast majority of people never finish the gallon. So if you could think you can do 2 liters per hour, I think you're probably wrong. I mean, challenge accepted. I'm impressed if you can, but this really needs to be by NG tube. And you can move things through the GI tract pretty effectively in about 4 hours. That is not going to be helpful for anything that's immediate release, right? So, aspirin, Tylenol, they are not going to be, this is not going to be effective. So I would say that this is only something that I would give to someone who takes a true sustained release formulation, like a ghost pill. And the end point, personally, I just say 4 to 6 hours and then just stop. But the traditional end point is that until the effluent is clear, in other words, all the stuff coming out of the bottom is totally clear. If you've ever done this, or if you've seen studies with this, the effluent never gets clear. So I don't think it's a great, it gets kind of brownish, and that's about it. Eventually I'm sure it's clear, but it's way too long. So I think if there's a question on at the end point, the answer may be that you do it until the effluent is clear. Clinically speaking, I think it's probably not necessary for the effluent to be clear. As I mentioned, ghost pills are probably the primary reason to use this. What I mean by ghost pills, if I've not used that term before, is pills that are with a hard outer coating that are designed to slowly release. So they're a hard outer coating that does not get absorbed, period. It's not an enteric coating, which gets dissolved in the small bowel, not in the stomach. It is a hard coating with a specifically designed system to release over a period of time. These are things like methylphenidate and bupropion, verapamil, so propranolol. I don't know if you guys can hear that, but they're mowing the lawn right outside my window now. So I can't hear myself think, but I'll do my best. The other indication is foreign bodies, and this is an image of a body packer. We don't really see body packers in Oregon, but it's certainly something that people use whole bowel for. I think more commonly for us would be lead paint chips or iron tablets. That would be something that is advantageous to push through the GI tract within 4 hours because they don't get absorbed very quickly. Obviously, anytime you're putting large volumes of fluid into the GI tract should be functional. So this sometimes comes up with things like calcium channel blockers, where they're hypotensive for a while and then they get bowel dysfunction because they're not perfusing their bowel. Obviously, that is a sign to stop. And I would even consider, refractory hypotension to probably be a relative contraindication to this. Clinically, feel free to talk to MBU about those indications. All right, we're still going to cruise through our whirlwind here. Moving on to other types of decontamination. Ocular decontamination, I think the norm for caustic injuries of all types, or even irritants, is 1 to 2 liters. The end point particularly for caustics, is the pain is improved and that the pH normalizes. Now, I wrote here 7 to 7.5. It turns out, and that's a great answer to a question on a test. It turns out that sometimes it is extremely difficult to get to that normal pH. And so in reality, between 6 and 8 is probably completely fine. But I think if they asked a question specifically on a test, I would answer 7.5 for a normal pH. Morgan lenses, if you haven't seen them before, they work really, really well. They're like a contact lens with a tube on them. And then you just run the fluid into the contact that's, right into the Morgan lens. Yeah, so if you have a damage to the cornea, there's two ways to think about that. Morgan lens is great for I was just exposed, and you can put them in there. If there's damage to the cornea itself, then there's kind of two ways to think about it. One is, no, you shouldn't put a Morgan lens in there, but you should irrigate really, really well, because this person has a very, very high chance of significant injury. So the other option is, besides a Morgan lens, is just to do the whole nasal cannula method, which I don't know how many of you have used before, but the idea is you just take the nasal cannula, you hook it up to the IV tubing, and then the fluid comes out and you put it on the bridge of their nose. So that's what I would do. If I looked in someone's eye and saw the whole cornea was denuded, I would probably do this method. I wouldn't put a Morgan lens in. Thank you for bringing that up, Hope. But I'd want to make sure that you are really, really irrigating, because that's the person that needs it. We do a lot of irrigating, and the person who actually has eye damage is the person that really needs it the most. So you just got to make sure that you're doing a really good job. Dermal decontamination is super straightforward as far as test questions go, I think. The fluid of choice is water. There's a lot of, the US Army talks about dilute bleach solutions and things like that. What we're talking about is hospital decon or pre-hospital decon, and it's going to be water. We recommend soap for decon, and not because it actually binds to any chemicals, but because it reminds people to shower. And it reminds them to get the problem areas between their fingers and under their arms and their groin and the bottom of their feet. But there's nothing magic about the soap that it's like, binding, it's not chelating the chemical or something like that. So dermal decontamination is all about volumes of water. The recommended time for an in-hospital decontamination is 2 to 5 minutes. Clothing has to be removed, of course. And there is some evidence that if you have like a local thing, like, very, very sticky, like asphalt or tar, that mineral oil will sometimes help. But that's not really, that's like local decon, not body-wide decon. All right, let me pause there, see if there's any questions. I'm going to keep going, but at the end, we can also stop for questions too. So just jot them down. So we've talked about GI decontamination, dermal decontamination. Now the toxin's already absorbed, it's in the blood. Can we eliminate it? So we're going to go through these: the alkaline diuresis, multi-dose charcoal, and hemodialysis. Because while we can use multi-dose charcoal to decrease absorption, like with salicylate bezoars, the other indications are to increase its elimination or excretion. All right, so alkaline diuresis is using sodium bicarbonate, bolus then infusion. The idea is you're increasing the pH. Sometimes it's of the serum, usually of the urine. And it's only really beneficial for a specific group of weak acids, mostly for clinically, it'll be salicylates and phenobarb. And phenobarb we see so rarely that it's really just salicylates. So how does it work? I will get into this a little bit, and then my next talk is about analgesics, and I'll have salicylates. So I think I'll go into details now and then kind of skip through it quickly then. But salicylate's a weak acid, as I mentioned. It's got a pKa of 3.5. pKa acids exist either as with a hydrogen ion, so they're not ionized, or they're ionized into salicylate and a hydrogen ion, and they are in equilibrium. And at the pKa, there's an equal amount of salicylate that is non-ionized and salicylate that is ionized. Why in the world is this important at all? Well, the reason it's important is because the non-ionized version of salicylate is the one that travels across membranes. When we talk about salicylates, we're talking about it is traveling into the brain or out of the urine. And so, but the charged molecule, the ionized form, does not easily go across the blood-brain barrier or travel in the kidney out of the urine. So at the pKa, we're in equilibrium. At physiologic, or I should say in the stomach, very low pH, almost all of the salicylate is non-ionized, so travels across membranes very well. And in the physiologic pH, most of our salicylate is ionized. And so if you looked at, when we get a salicylate concentration, we get them all. So we don't know the difference. But if you looked at any particular time, hopefully most of your pHs are 7.4. Hopefully, you'll have 90% of your salicylate is going to be ionized, so not traveling across membranes very well. And so a little bit, just this little portion that's non-ionized will make it into your brain. Once it's in your brain, it will ionize again and get trapped there a little bit. So diuresis. So this is, say someone just took a salicylate overdose, their salicylate concentration is not high yet, we're in equilibrium. This is the plasma, this is the urine, this is, let's just call this brain. I called it tissue, but let's just call it brain, right? So notice a couple of things. One, the plasma has a higher pH than most of the other places. The end organs have a relatively acidic pH, so does the urine usually. And so you have salicylate in your blood. Most of it is ionized and not traveling anywhere, so sitting in your blood. A small amount is non-ionized, travels into your brain, and then gets ionized and gets trapped there. So this is why salicylates work for headache. A small amount of the salicylate makes it into your brain and then gets trapped there and does its thing. Your headache goes away. That's all well and good. This portion over here is really about glomerular filtration rate. So it's blood flow to the kidney. It's not really affected by ionization at all. It's just, just however much blood flow is going to the kidney at that particular point. And then in the kidney, because the pH is low, most of the salicylate gets trapped there as an ion and can't get reabsorbed. So you're urinating out a lot of the salicylates, and so you get rid of it pretty quickly. So what happens if your plasma pH drops? If your plasma pH drops, then more of that ionized salicylate becomes non-ionized, and it transfers into the brain where it gets trapped in the brain. And so this is why we always talk about, when you intubate someone with salicylate toxicity, their pH drops, you can expect their CNS salicylate concentration to increase, and obviously lead to salicylate toxicity, CNS salicylate toxicity, neuroglycopenia, and all those things. But what if we alkalize? We give bicarbonate to increase the plasma pH. We give bicarbonate to increase the urine pH. Then what we're doing is we're shifting some of that non-ionized salicylate back into the plasma, and then we are shifting a lot more of that non-ionized salicylate into ionized form in the urine, and we're not reabsorbing it. So, is this really effective? Yes, it's ridiculously effective. If you can get the urine pH up to 8, then you have a clearance rate that is almost equivalent to hemodialysis. So super, super effective. Is it possible to get the urine count up to 8. Really, really hard, like super, super hard. But we can do it. The thing that usually limits us is the potassium. Honestly, they're usually hypokalemic, and makes it very difficult to get their pH up high. But if you can increase, you see this curve. This is the excretion curve for the clearance curve for salicylates. You get their pH over 7. That curve is really, really steep. So that difference between 7 and 8 is really, really huge. All right, what else can we do? Multi-dose charcoal, I mentioned it before to decrease absorption, but now I'm going to talk about it as an elimination tool. What we're talking about is typically 50 to 100 grams Q 4 hours. While the indication is until they're not absorbing anymore, I think I usually just say 4 doses. I think it's easier, and then we can kind of reassess. But theoretically, you can keep giving multi-dose charcoal for a very, very long time. It doesn't cause any electrolyte abnormalities or any other difficulties like that. So as I mentioned before, binding unabsorbed drugs. So for example, salicylate, Bezor, you give multi-dose charcoal to decrease absorption. But I want to talk about the other 2 indications. Sorry. So this is the Pharmacobezor. If you haven't seen one, this is actually this wasn't salicylates. This was verapamil. You see like the white drug and then the blue tablets, and you can kind of see them all kind of agglutinated together. That was kind of an interesting picture. And that sometimes forms in the stomach, obviously. But there's this other thing called enterohepatic circulation, which I know you've all heard of, but the drug gets metabolized in the liver or handled in the liver, gets secreted through the bile duct into the duodenum, and then gets reabsorbed in the small bowel. So this is one of the reasons why some drugs have very, very long half-lives, because they keep getting secreted into the bowel or the small bowel, and they get reabsorbed, and so the effective half-life is actually quite long. What the idea with a multi-dose charcoal in this case is fill the small bowel with charcoal and block that reuptake. So this is particularly effective for a couple of things, most of which, half of the things on the screen there we'll probably never see or very rarely. So I think the ones I would remember are carbamazepine, salicylates, and amitriptyline. Little evidence for amatoxin as well. So I think there's a lot of odd ones, but I think carbamazepine, salicylates, and amitriptyline are the most common, probably the most significant one that you might get a question on. Last reason to use multi-dose charcoal is something called gut dialysis, which it's a term I absolutely hate, but it's the term that's used. So remember, the lining of the intestine has all these little villi, right? And then if you get really, really close, you have this like individual villus. And if you cut that, if you just slice it here and take a look, what you have is a row of cells, a basement membrane, and then blood vessels. So if you have a toxin in these blood vessels, it is literally 2 cells to get to the to get to the lumen of the intestine. And there is some evidence that a lot of things that are in the blood will travel across into the lumen of the GI tract and then come right back in and keep getting secreted and absorbed based on the gradient, the concentration gradient. So in particular with phenobarb and theophylline, we know that giving charcoal, filling up the small bowel with charcoal, will draw some of that toxin, some of the phenobarb or theophylline out. How do we know this? There are several studies where they gave intravenous phenobarbital. Half the patients got activated charcoal, the other half did not. And the people who got oral activated charcoal, even though the phenobarb was given IV, had half-lives that were about half as long as the group that didn't get activated charcoal. So it is an effective method of elimination. And the two things I would remember are phenobarb and theophylline. Obviously, we don't see a lot of theophylline anymore. We don't actually see a lot of phenobarb a lot anymore either. Too bad, but I think that this could potentially be something that would be asked about. Okay, so last portion of enhancing elimination is hemodialysis. So hemodialysis, I think you all know that you draw the blood out of the patient, it goes through a filter and it goes back to the patient. Let's hone in on this filter here for a second. And the blood is flowing from the patient. It's flowing through the cartridge and then back to the patient. So no obstruction to the blood flow, but the flow does slow down when it enters here, and you have this dialysis fluid. This little tube is a semi-permeable membrane, and the dialysis fluid is going in and getting sucked out the other side as dialysate, and the blood is going in this side to this side. So if this blood right here, forget about toxins for a minute. If it's got a potassium of 8, the dialysis fluid has a potassium of 3 or 4, then potassium will flow out from the blood because it's a 8 milliequivalents per liter, and it's going to go into the dialysate. Same thing with toxins. If you have a salicylate concentration of 100, hopefully the dialysis fluid has a concentration of 0, then salicylates will go through the semi-permeable membrane and then end up in the dialysate. So that's sort of true for all of the things that are dialyzable. There's a bunch of mnemonics for I stumble. I don't know why that's a mnemonic, but it's a kind of a complete list of things that are dialyzable. In reality, we only probably dialyze this group: lithium, alcohols, salicylates, rarely valproate. But there is a big long list of things that do not end up in mnemonics that are potentially dialyzable, and acetaminophen is another one of those that we're probably dialyzing a lot more than we were before. But if you like mnemonics, I stumble is one of them. And then, but I think most of you recognize the alcohols, lithium, and salicylates are probably the most common things that we're using hemodialysis for. All right, last section on antidotes. I'll go through this relatively quickly, but just stop me if you have questions. So naloxone. So we know that opioids bind to lots of opioid receptors, in particular the mu receptor, in different areas of the brain, and cause all of their effects: euphoria, as well as bradypnea and apnea. And there's also mu receptors throughout the body outside of the CNS, but they're less concerning. They have more to do with things like constipation and those types of things, ileus. So naloxone is a competitive antagonist, and I think that's an important concept. You are trying to compete with the opioid that is there to try to decrease the overall opioid effect. Dosing is fairly controversial, I'd say. Kind of, for me, it depends on the indication, but this was from a New England Journal article that started off with, a pediatric and an adult dose, the adult dose being 0.04 milligrams, which I agree with for sure. 0.04 will reverse most opioids. I'll talk about exceptions in just a minute, and particularly in the healthcare setting. As far as I'm concerned, in the pre-hospital setting, you can use as much as you want because those are, scary situations, etc. But escalating from 0.04 and then over a period of time getting up to higher doses of naloxone. I don't normally go to 10 or 15, but this is what the review article said. But I think the important concept being start low and then move up. Use the lowest effective dose is what it comes down to. The indications for naloxone are respiratory depression. I put in CNS/respiratory depression. I think it's reasonable to wake people up sometimes, like if it's a small child that ingested heroin or fentanyl or morphine or something like that, then you can wake them up and that's fine. But for most people who are have substance use disorder and using high doses and are at risk for precipitated withdrawal, using the lowest dose you can and only treating respiratory depression seems like the right way to go. There are pretty much no contraindications to naloxone, which is great. The studies done on naloxone escalated the doses up to 70 IV, 70 milligrams IV, in a group that did not have substance use disorder. They didn't have an opioid tolerance and didn't develop withdrawal symptoms. So I'll talk about that as a separate thing. But if it's a child or someone who doesn't use chronic opioids, they used 70 milligrams of IV naloxone with almost no side effects. I say almost because their blood pressure went up 5 millimeters of mercury. That was considered a side effect. So I don't consider that a side effect. But if we have someone who has a dependency or has tolerance and develops withdrawal, then giving too high a dose of naloxone can induce precipitated withdrawal. Precipitated withdrawal is usually just uncomfortable, but has occasionally led to a big norepinephrine surge, and in people who are predisposed to it, has led to ventricular arrhythmias. It has led to seizures. So all of those things, even though normal natural opioid withdrawal doesn't lead to those types of things, precipitated withdrawal can and has. Now, there's probably, again, some predisposition in the patient, but you don't know that they have a predisposition because they're unconscious and not breathing. So hard to predict that. So that's why we kind of always try to use the lowest effective dose. And whether you're giving, it's an opioid overdose and you're not giving naloxone, or you are giving naloxone, I think cardiac monitor has to be in place, a saturation pulse ox, and preferably an end-tidal CO2 to see if they're retaining carbon dioxide. But I think those would be the ideal. All right, naloxone is the big one, obviously, that we use the most. Flumazenil is all of the concepts that naloxone are the same with flumazenil. It is a competitive benzodiazepine receptor antagonist. The dose is 0.2 milligrams every 1 to 2 minutes. The old literature and old literature says give 2 milligrams. That I would consider to be the equivalent of naloxone old literature saying give 2 milligrams. We shouldn't be giving 2 milligrams of naloxone for most patients to start, and we shouldn't be giving 2 milligrams of flumazenil to most patients to start. Would you, what is the basis for giving this? If you have a pure benzo overdose, and they have respiratory depression or CNS depression that's causing obstruction. So the way I think about this is if you've made the decision you're going to intubate someone who has a pure benzo overdose, prepare for intubation, and then you can use flumazenil to wake them up and avoid intubation. But that's sort of I think that's kind of the indication, is avoiding intubation. There are many randomized controlled trials for flumazenil. The response rate is quite high. If you took a benzo, you usually get it reversed. And there's lots of literature that the rate of benzo withdrawal, in fact, there's not really, if you're using it with this dosing, there's really very little risk of benzo withdrawal at all. Again, with this type of dosing, not giving 2 milligrams IV, their seizure risk is incredibly small. But if they took something that, like a TCA, that causes seizures, and the only reason they're not seizing is because they took a benzo, there's a risk of seizures for sure. And I think that is a relative contraindication in our guidelines. So other contraindications, so they are at high risk for seizures, or they have benzo dependence. And I think this has probably been overstated a little bit. Benzo dependence is becoming less and less common now, which is obviously a really good thing for all of us. But if you are benzo dependent, large, chronic large doses of benzos, then there's certainly a possibility you could cause benzo withdrawal, although I think that is incredibly rare, and the same monitoring parameters as naloxone. Anti-lyrium, or I'm trying to remember what the German version is called. It's something very similar, but that's what we have now because they're not making anti-lyrium right now. So physostigmine is an inhibitor of acetylcholinesterase that is meant to reverse antimuscarinic toxicity. It doesn't quite directly compete with the antimuscarinic agent. The muscarinic antagonist is sitting on the muscarinic receptor. This increases acetylcholine. That acetylcholine then competes with the antimuscarinic agents. So but it is just like naloxone and flumazenil. It's a titratable drug. So the more the patient, you can give them a little bit, and then you can find the lowest effective dose. The one thing that's really separate from the rest of the other antidotes we talked about so far is this is relatively slow in onset, and it probably has a lot to do with its indirect effect, right? It's not binding that receptor, it's binding to acetylcholinesterase and then decreasing the metabolism of acetylcholine, and then acetylcholine has to build up. And so it takes a good 10 minutes before it actually you see its peak effects. The dose is 1 to 2 milligrams over 5 to 10 minutes. And then we would wait 10 minutes after that, the end of the dose, to evaluate them to see if they need more. Physostigmine is plagued by 3 cases of asystole, which is a really bad side effect. Really bad side effect. Let me share you these cases because they are weird at best. They're from way back in, I think, 82. This is the patient's EKG, and they were in status epilepticus at the time. Despite taking amitriptyline at a heart rate of 75, and that QRS is anywhere from 240 to 400 milliseconds. So the first thing I'll say is, I wouldn't be waking this person up, I'd be resuscitating them, but whatever. This is the next person, bradycardic after taking amitriptyline. A little weird. QRS was, I forget what that one was, it was 140, I think, something like that. That person got 4 milligrams IV push of physostigmine, which is way out of what anyone would do these days. These 2 plus a third got asystole. That's really, really bad. We should not gloss over that. So it's a predictable effect. If you increase acetylcholine in the synapse, you're going to increase acetylcholine's effects, which include bradycardia and asystole if you give too much. So, but as long as you stick with the dosing protocol that we have, then we should be completely safe from any of these issues at all. There's a couple of studies with over 1,000 patients now. The response rate is really excellent. Intubations decrease from 30% to 9%. ICU admissions decrease. This is the rate where over 1,000 patients, the rate of bradycardia and seizures really, really, really low. So the dosing, what we did was we fixed the dosing. I think is really what it comes down to. We should respect these expect seizures, even though they're 99% of the time they won't happen. Expect bradycardia 99.7% of the time it won't happen. And I think we're safe using that medication. That said, they are typically we're typically giving the FISO to the mild to moderate antimuscarinic. And what I mean that is, like, if you took diphenhydramine and you're in status epilepticus and your QRS is 180 milliseconds, I don't care if they're awake or not. Don't give physostigmine, right? The physostigmine is to clear someone's mentation. That is why we're using it. It will not fix their QRS and it will not fix their status epilepticus. I suppose it might, but I don't think it will. Treat them with supportive care. Forget about FISO, move on. FISO is really most effective for the person who just has, encephalopathy from antimuscarinics. They're confused, they're picking at things, they're climbing out of bed, they're hard to control, they're in restraints. That's the person that uses this, that gets this drug, not the severe ones. And I think we touched on the rest of this. All right, just a couple more things. Yeah, so sorry, I missed some of the comments. So there is, getting back to naloxone, the one of the side effects of a big, fast dose of naloxone is that and we've all seen this, you've seen it in the movies, you've seen it in person, the person is essentially dead, and then all of a sudden, they take that gigantic breath. And yes, so that is a risk for, it's a risk for barotrauma from a strange reason. There's really good research from this anesthesia group that looks at when you give a high dose of naloxone, what kind of reactivates first. And the diaphragm reactivates before the neck muscles do. So what ends up happening is you have a closed glottis because your tongue is sitting and blocking your airway, and then all of a sudden your diaphragm starts working again, and you start to try to take this really big deep breath against a closed glottis, and you get barotrauma. The other aspect of naloxone precipitator withdrawal is that big norepi and epinephrine effect. When they get a big bolus really quick, they get this big norepi effect, and that also affects the cardiopulmonary system. You get, very, very quickly get pulmonary hypertension and you get dysrhythmia. So that is very problematic. All right, we're almost done. We'll take a break. I know we've been at this for a while, but this is sort of the big meaty lecture of the morning. So IV lipid emulsion is a bunch of lipids. Nothing really that fancy about it. Most of the time we use Intralipid. Intralipid is a brand, and so generally speaking, we would use intravenous. We would call it intravenous lipid emulsion. And typically, we would give a dose that's something along 1.5 milliliters per kilo. And one of the tricky things is this is a drug that we are giving in milliliters and not in milligrams or grams. So just take note that this is a milliliter per kilo of a 20% emulsion. I don't think they would ask you about anything else, like using a 40% emulsion or something, but it is 1.5 mils per kilo. And then you can repeat that up to 8 total. So the typical max is 12 milliliters per kilo per day. So that's why we say 8 boluses. You can also, specifically for local anesthetics, you get 1.5 milliliters per kilo bolus, and then you give this infusion 0.25 milliliters per kilo per minute for about 20 minutes. That is not the case for things that are much longer acting, but that is the local anesthetic dose. So indications are still a big question mark for most people. I think we all believe in this lipid sink theory, which means that these little globules of lipid go in your blood, and if there's a lipid soluble drug, they just get caught in there. So verapamil will just get caught in there, and then or propranolol or something, and then that little globule gets delivered to the liver, where you either metabolize or excrete the drug. And so it takes it very quickly out of the circulation, and then the drug diffuses from the end organs into the blood again. It gets bound by more globules of lipid. So contraindications, I don't know of any. Adverse effects, there's at least a theory for giving way too much. If you follow our guideline, we won't do that, but we do have a case report of someone getting something like 2.5 liters of intravenous lipid emulsion. And the biggest issue, they didn't get any fat overload syndrome or pancreatitis, or acute lung injury. But it's very difficult to get labs because most labs are colorimetric. And when the color is white, there's not much of it just gives you an error. And so there's a lot of labs that you can't get anymore. So stick with our limit of 12 mils per kilo per day, and we'll be fine. All right, I think that's all I have for now. Let me stop and see if there's questions. We had a bunch. I don't know if I missed any in there, but I don't think.